And I couldn't do that with my screen shared. Right. Just a couple housekeeping items before I hand it over to our presenters, but please do stay on mute. If you're not speaking, you're able to raise your hand in Zoom or use the chat feature to ask questions. We'll have a couple people moderating the chat to make sure anything you want to ask gets asked. We are Main Pro accredited, so if you please make sure your full name is visible on the Zoom link, or you can message me privately on the chat just so I know who to send the certificate to. Just a little plug, please sign up to our LMPCA newsletters and you'll get future information about future similar events or other practical information. I know most people probably are already signed up since you're here tonight, but and then just so everyone's aware, this meeting is being recorded and we'll share the recording and the slides when they're within about a week onto our website there. So I just wanted to quickly let everyone know what the LMPCA is. So really it's a forum where these primary care providers can come together within London Middlesex, collaborate, communicate, and we're really acting as that primary care voice within our local health system. And I've noted there how you can connect with us if you have questions, comments, concerns, anything to do with primary care or any projects that either we're working on, or we also work very closely with the Middlesex London Ontario health team. So I'll drop that information into the chat as well. Just the listing of our objectives tonight. Won't read them out, but it's really about learning about how the management of heart failure within primary care in the community. So our LMPCA program does receive in-kind and financial support from Thames Valley Family Health Team, as well as the Middlesex London Ontario Health Team, just in terms of some administrative and logistical supports. We don't foresee any conflict of interest there. So then I'll just ask our two speakers today to verbally declare any of their disclosures. Dr. McKelvie first.
There we go. It's just what you see on the screen in terms of financial disclosures.
And Chris Licskai speaking. For me, I do have grants and research support to Novartis and AstraZeneca, and I have participated in speakers bureaus, including the three companies that you see on the slide.
Great, thank you so much. So I'm gonna welcome to both of you, and thank you so much for being here to present to us. I'll hand it over to you now, and I know you have your own slides there. Perfect.
Great, so.
Are you seeing the whole slide properly on the screen?
Yes, we are.
Okay, thank you.
Sure. Okay. So I'm going to start off the presentation tonight, and it's a pleasure to be here, and I welcome everyone that's participating. We look forward to a lively discussion, and hopefully we can answer the questions you have regarding the management of heart failure. So next slide. So throughout the presentation then, it would be good if you can think about this case. So this is a gentleman who's in his 60s, a couple of exacerbations within the last 12 months with regards to his COPD. He's not had any emergency room visits or hospitalizations for the COPD. Now, you probably wonder why I'm talking about COPD as a cardiologist, but we're going to move into the heart failure part right now. So He's in your office and he has a history of ischemic cardiomyopathy along with diabetes, a long history of smoking. His PFTs are, as you see, described there. And at the very bottom of the screen, the current therapies are listed. He has some therapies for his COPD. And of course, he's got the therapies for his heart failure with reduced ejection fraction. And his ejection fraction sits in the range of about 30 to 35%. Next slide. So I'm often asked the question, why do my patients need to take so many medications for their heart failure? So hopefully by the end of this tonight, you'll have a further appreciation as to why patients do need more than one therapy to effectively treat their heart failure. Next slide. So to begin with, I view heart failure as a cycle. In other words, it's not something that we cure, it's something that we manage. And about half the patients are diagnosed through acute heart failure and they're hospitalized. About the other half are diagnosed in the outpatient setting without initially going into hospital. Many of them do end up being hospitalized. Obviously, in the course of the hospitalization, we stabilize them. They are discharged from hospital, and ultimately, they frequently will become unstable and go back into hospital. And in the center there, you see end of life planning and death, because for heart failure patients, as I said, this is a matter of managing them, not curing them. So we do have to take that into consideration. Next slide. Heart failure is a condition that occurs mainly in those over the age of 65. And this slide just represents the change in the population in terms of age over the last really 100 years. Oh my gosh, when I think about that, 1950 to 2050. The important part about this slide is that by the time we reach 2050, about 40% of the patients will be over the age of 65 versus only about 5% back at that time 100 years ago. So this condition is not going away. If anything, it will be increasing in prevalence over the next 25 plus years. So it's something we need to come to grips with and work towards managing more effectively. Next slide. So in Ontario, this represents the situation with regards to heart failure. There's over 280,000 people living with symptomatic heart failure. And not shown on this slide, there's probably another 250 to 300,000 people living with asymptomatic left ventricular dysfunction who ultimately may convert to symptomatic heart failure. The prevalence and incidence is, as you see on the screen, along with the mortality. And importantly, the 30-day readmission rate following hospitalization sits in the range of about 20%. In our area where we live, there are over 11,000 people who have symptomatic heart failure, and LHSC hospital admissions back in 2019 to 2020, and they're pretty similar now, was close to 1,000 admissions a year. Next slide. So every time a patient gets admitted to hospital, you know, we don't think too much about it, but as you can see here in this slide, heart failure patients, the course of their life is one of exacerbations and then recovery. And you can see from the graph that they kind of dwindle down over time. Now, what I meant by saying that we don't think much of a hospitalization, the residents will fix them up, send them out. And then when I said, oh, 20% get readmitted within 30 days, just push the button there again, Chris. This readmission rate has significant importance. You can see there on the right that for the first readmission, their median survival goes down to about 2.5 years. But very quickly, if a patient has two readmissions, their survival rate drops to about 1.5 years. And by the time they're on their 3rd and 4th, their survival is less than a year, expected survival. Next slide. So people have often said, why do I have all my patients, on medical therapy? Well, this is another reason. When you think about cancer, no one would hesitate pulling out all the stops to treat people with cancer. Heart failure has survival rates that are less than most cancers, certainly common cancers like breast cancer for women, prostate cancer for men. You're much better off to have one of those conditions than a diagnosis of heart failure. About the only common cancer is lung cancer that has a significantly greater or less survival than heart failure. So we need to start thinking about heart failure as a cancer with certainly rather limited survival. Next slide. So the goals of therapy for patients with heart failure. Well, if this was a presentation from the 1970s, we'd be saying we just want to improve their symptoms, that's it. But we've advanced quite significantly, and now our goals of therapy are obviously to improve symptoms, but to reduce hospitalizations, reduce mortality, and have a prompt up-titration to target doses of medical therapy. And we'll talk in a few minutes about the pathway to quadruple therapy, because yes, they do need, for reduced EF heart failure, at least 4 therapies. Next slide. So we commonly think about the therapies that we use to treat heart failure patients breaking down into roughly 3 big categories. So the sympathetic nervous system with regards to beta blockers, push the button again. The renin-angiotensin-aldosterone system, and push the button again. And finally, the natriuretic peptide system. So of these 3 systems, the sympathetic and the renin-angiotensin-aldosterone system have been addressed for many years. The natriuretic peptide system has only more recently been addressed. Next slide. So, of course, I would think with regards to everyone on this Zoom meeting tonight, well aware of the fact that ACE inhibitors have been for years the backbone of heart failure management. And it was 30 some years ago that we started with the consensus study looking at the sickest of the sick heart failure patients, right through to solve treatment and prevention, solve treatment being those with low EF and they were symptomatic, to solve prevention being those who had asymptomatic left ventricular dysfunction. AIR and SAVE were post-MI along with TRACE. And finally, ATLAS demonstrating that it's important to get to target doses of ACE inhibitors, because if you don't, then the outcome is worse. Next slide. In terms of ARBs, we have candesartan and other ARBs. It was back about 29 or so years ago, almost 21 years ago, that it was demonstrated that if a patient couldn't tolerate an ACE inhibitor, then an ARB such as candesartan would be as effective in those who are intolerant. So we had the idea that ACE or ARB. Next slide. In the same time frame, there were a number of studies looking at the use of beta blockers. And on this slide, there's the MERIT-HF study with metoprolol CR up in the upper left, the US carvedilol study on the upper right, the Copernicus study again with carvedilol on the lower right, and CBIS-2 with bisoprolol on the lower left, all uniformly showing that in with heart failure with reduced ejection fraction, that beta blockers were efficacious. Now, I will draw to your attention that the MERIT-HF study with metoprolol CR is not the metoprolol we have in Canada. Metoprolol succinate was used in that trial. We have metoprolol tartrate in Canada, which is not the same therapy. So essentially, we have carvedilol and bisoprolol that we would use in heart failure patients in Canada. Next slide. As well, we talk about the renin-angiotensin-aldosterone system, and the emphasis study demonstrated with the Plerinone that if a Plerinone was added on top of ACE inhibitor and beta blocker, there was further benefit. As well, a number of years before this, spironolactone was also demonstrated to be beneficial on top of ACE inhibitor digoxin therapy, but it wasn't used in combination with beta blocker therapy because the trial with spironolactone was carried out before beta blockers were commonly used. Next slide. So what about the evidence for newer heart failure medications, heart failure with reduced EF? We have advanced in the last 20 years. This study, the Novartis study Paradigm, looked at valsartan and sacubitril, otherwise known as Entresto. And this was a very unique and bold study because it took Entresto and put it up against enalapril. Enalapril was the gold standard ACE inhibitor. It was used in the SOLVE study. And what they found was that compared to enalapril, Entresto significantly reduced death, heart failure hospitalizations, the risk of sudden death. So Entresto was clearly shown to be superior to enalapril therapy and to ACE inhibitor therapy generally. Next slide. So the Paradigm study was used or was carried out in the outpatient setting, but the question became, would it be useful to start this in the inpatient setting? And this slide shows the Pioneer HF study that demonstrated that if Entresto is started in hospital compared to enalapril, you see the slide on the left looking at N-terminal proBNP, demonstrating that Entresto significantly reduced N-terminal proBNP compared to when the patient was using enalapril, and that's significant because declines in N-terminal proBNP will predict better outcome. And then that slide on the left, you see the patients were then put into an open label component of the study. And of course, when they were put onto Entresto, coming off the enalapril, the N-terminal proBNP came down and equaled that of the people originally randomized to Entresto. The slide on the right, or the panel on the right, looks at the probability of CV death or heart failure hospitalization in those patients initially randomized to Entresto versus enalapril. And you can see during the randomized phase of the study that Entresto resulted in a lower rate of CV death or heart failure hospitalization. And in the open label phase, continued to provide better outcomes than those who were originally randomized to enalapril. So it made the point that in patients who were hospitalized, it would be good to think about switching them over to Entresto if they were on an ACE inhibitor to begin with, or even consider starting them on Entresto if they were a de novo diagnosis of heart failure. Next slide. And this led to the guideline recommendations in 2021 that an ARNI, which of course is Entresto, be used in place of an ACE or an ARB in patients with heart failure, reduced EF who remain symptomatic, and with appropriate doses of guideline-directed medical therapy to decrease death and heart failure hospitalizations and symptoms. We also recommended in this iteration of the guidelines that patients admitted to hospital for acute decompensated heart failure with low EF should be switched to an ARNI, which of course would be Entresto, and then stabilized before their discharge. And as well, we boldly stated that patients admitted to hospital with a new diagnosis of heart failure, reduced EF, should be treated with ARNI as first-line therapy as an alternative to either an ACE or an ARB. Next slide. So what about other therapies? Well, I know you're all well aware of the use of SGLT2 inhibitors in patients with diabetes, and certainly the EMPA-REG study a number of years ago looking at empagliflozin in patients with diabetes and cardiovascular risk, interestingly and surprisingly demonstrated that heart failure hospitalizations were reduced in that population that were included in the EMPA-REG study. And subsequently in other studies with SGLT2 inhibitors in patients who are diabetic, the same result was found. So in effect, it was a surprise. We kind of backed into the whole idea that maybe an SGLT2 inhibitor would be useful to treat patients with heart failure, certainly with diabetes. But when you look through the basic science and the rationale for using it generally in heart failure, you can see based on this slide that there are a lot of similarities between heart failure patients and those with diabetes. In other words, even in patients who have heart failure without diabetes, SGLT2 inhibitors potentially would be of benefit. And this led to the design of large randomized controlled trials of patients who had heart failure with and without diabetes, and they were designed as heart failure trials, and the SGLT2 inhibitor was being used as a drug to treat heart failure. Next slide. The first of these to be reported was the DAPA-HF study with dapagliflozin, and as I said, it was designed as a heart failure study. They were randomized to dapagliflozin or placebo, and they had all the other therapies, ACE, beta blocker, MRA, and in a number of cases, Entresto as background therapy. And the results demonstrated in terms of the primary outcome that yes, it achieved that, reductions in death, heart failure hospitalizations, or urgent heart failure visits. Next slide. Oh, we must have blocked out a slide, but that's okay. Oh, no, we did. That's okay. We'll just go to the next one because that means I can quit sooner. Anyway, there was another study called the EMPEROR-Reduce study, which was designed the same way as the DAPA-HF study. Heart failure trial, background therapy was excellent. And then as all good cardiology studies go, we pooled the data and we looked at it. And when you pool the data, the top part of this slide showing with diabetes, you can see that there's a reduction in hospitalization for heart failure or cardiovascular death by diabetes status or with diabetes. But interestingly and importantly, even those patients who did not have diabetes, which were about 50+% of the population of each of these studies, again, the benefits were there, leading to the conclusion that an SGLT2 inhibitor is being used to treat heart failure, and it just happens to have a side effect of reducing blood sugar. Next slide. So in the guidelines in 2021, we stated explicitly that an SGLT2 inhibitor such as dapagliflozin or empagliflozin should be used in patients with heart failure with reduced EF, with or without type 2 diabetes, to improve symptoms and reduce mortality and morbidity. Next slide. So now we're coming to answer the question, why does my heart failure with reduced EF patient need all these medications? Well, this slide kind of sums everything up. And if you compare patients who are on ARNI, beta blocker, MRA, and an SGLT2 inhibitor versus those with more limited conventional therapy that we used years and years ago, just an ACE or ARB and beta blocker, you can see that in terms of event-free survival on the left side and overall survival on the right side, that those having all four drugs on board end up having significantly increased survival compared to those who are only on more limited therapy, making the point that we do need to be aggressive in this patient population, and we do need to use all 4 therapies as tolerated. Next slide. So what are the recommendations? Well, the Canadian Cardiovascular Society guidelines came out stating that yes, those with heart failure, reduced EF less than or equal to 40% should be on one of the drugs from each of these 4 classes. And you'll notice that this is aligned in a way that's different than previous guidelines, where we have them all on the same level. In other words, you may need to start the beta blocker first, and then add in an SGLT2 inhibitor, and then come back and do the ARNI, and then add in the MRA. The most important thing is that they end up being on one class or one drug from each of these classes. The other important point, push the button again there, Chris. The other important point that came out in the guidelines was we need to do this aggressively and in an expedited fashion. It may come as no surprise to any of you that it can take a year or a year and a half or 2 years to get patients optimized. And during that period of time, we are losing lives and we are accumulating hospitalizations. So in the guidelines, we stated we should do it briskly. So 3 to 6 months would be the ideal goal to get these patients optimized. Next slide. So that's all very well and good. We've talked about heart failure with reduced EF. And if this was, 15 years ago, this would now become about a 30-second presentation about heart failure preserved EF. But we now can talk about newer therapies. Next slide. So this was the landscape back a number of years ago. We had CHARM preserved with candesartan, PEP-CHF with perindopril, I-preserve with irbesartan, TOPCAT with spironolactone in patients who had heart failure, preserved ejection fraction. The ejection fractions varied in each of these studies from being over 40% in CHARM preserved to being over 45% in I-preserve and TOPCAT, and similarly PEP-CHF. And what you see from this, the curves are separating, but statistically they didn't reach their primary endpoints for the overall outcome of the study. Next slide. However, the SGLT2 inhibitors were on the horizon. And just as it was with heart failure reduced EF, from a basic science point of view, people started to think that maybe this class of drug would be beneficial in patients with heart failure preserved EF. So again, they came back, and this is, of course, the Emperor preserved study results, but they came back and said, okay, let's do a heart failure preserved EF study. The patients will be on background therapy, whatever you think is appropriate to treat this condition, and they'll be randomized to, in this case, empagliflozin or placebo. And this study reported out first, demonstrating that it reached its primary outcome. There was no reason to make excuses. This significantly reduced the primary outcome of cardiovascular death or heart failure hospitalizations. Next slide. And of course, the DELIVER study with dapagliflozin, same type of trial design, in effect, demonstrated the same outcome, that with regards to death, heart failure hospitalizations, or urgent heart failure visit, that dapagliflozin compared to placebo significantly reduced this primary outcome. Next slide. And when the data were pooled, looking at this slide, looking at DELIVER and Emperor preserved, the top panel shows cardiovascular death or heart failure hospitalizations. You can see that the pooled data showed significant reductions. Cardiovascular death, again, significant reductions with the pooled data, and heart failure hospitalizations, significant reductions with the pooled data. So now we have a therapy for heart failure preserved EF that significantly reduces mortality and morbidity, and each of these studies met their primary outcome. Next slide. So this slide just points out the benefit of various molecules across the spectrum of left ventricular ejection fraction. So you see at the top dapagliflozin and empagliflozin basically reiterating what I just discussed in the previous few slides, that it doesn't matter whether the ejection fraction is reduced or preserved. An SGLT2 inhibitor, specifically dapagliflozin and empagliflozin, will have a significant reduction to reduce CV death or heart failure hospitalizations. So when you're thinking about the treatment of heart failure in a patient who you don't know the ejection fraction, then an SGLT2 inhibitor could be the first drug you start because you know it will be effective regardless of ejection fraction. The panels down below are looking at an ARB, Entresto being the ARNI, MRA, and even digitalis, because post hoc subgroup analyses looked at each of these studies. So for the ARB, you can see that in the range of 40 to about 60% or so, 65%, that there potentially would be benefit from an ARB, candesartan. Entresto as well, you can see that in the range of 45 up to about 55%, there's benefit. The MRA the same. And interestingly, even digitalis. And what's the lesson from this? Well, when we're talking about heart failure preserved EF, especially patients who are in the range of 40 to 55%, that not only would you use dapagliflozin or empagliflozin, you would certainly consider using an ARB or spironolactone. You can't use Entresto in Ontario because it doesn't have the HPB approval. And of course, there are issues, there's no LU code. But if you drive down to, I guess it's Port Huron coming from London, or Buffalo, however you want to get across the border, Detroit, the FDA says that you can use Entresto for heart failure preserved EF. So if you cross the border, Entresto is effective in that patient population. Next slide. So where are we? I've made the point that people need 4 drug therapies to treat heart failure with reduced EF. I've also made the point with heart failure preserved EF that they should be on SGLT2 inhibitor and the other medications we talked about. It's important to realize that in our system, these patients need to be optimized aggressively, and we're going to talk a bit further about how this can be done in primary care. But you see our friend here, this case one, this 64-year-old gentleman, someone did ultimately optimize him. He's on Entresto at the full dose. He's on bisoprolol at the full dose. He's on aldactone at the full dose. He was on bisoprolol at 5 to begin with, and he was on aldactone at 12.5 to begin with. And he's now on the full dose of both of those. And someone has started him on dapagliflozin for Forxiga at the 10 milligram dose, which is the dose we customarily use. So it's important that we optimize these patients, and certainly this can be done by all healthcare providers. Next slide. Now, this is how we actually perform in Ontario. So you can see here that we don't optimize patients effectively. ACE, beta blocker, MRA, triple therapy, you see across the board how poor we are with this. And this is why I'm emphasizing that we need to change the system, because now we don't have just 3 drugs, we have 4 drugs that we have to get on board for these patients. And remember, if they're not optimized, we're accumulating hospitalizations, and even more importantly to the patient, their risk of dying is increased. Next slide. So now we come to how can primary care start to effectively optimize these patients. And you're going to hear more from Dr. Licskai a bit later in this presentation. And this is just a preamble, I guess, an hors d'oeuvre, so to speak, with regards to best care. But next slide. We've done studies, and this has been published in the Canadian Journal of Cardiology, showing that in a primary care setting, with the support of best care, if you look at the ARNI baseline versus most recent follow-up, the same applies for beta blocker, MRA, and an SGLT2 inhibitor, that with the support of best care, these patients are actively and aggressively optimized. And if you look at quadruple therapy, in this study, it was in the range of 35 to 40%, but looking at our more up-to-date data, 53% have been optimized with the use of best care. So it is possible with support in primary care to effectively optimize these patients. Next slide. In terms of other things we looked at in the data that was published in the CJC Open, hospital admissions were significantly reduced, as you would expect, in those patients who were optimized. Emergency room visits were significantly reduced. And importantly, the quality of life in patients were either improved or remained stable with optimization. So yes, it can be done. Yes, it needs to be done, and we will get significant benefit when we do it. Next slide. So now we're going to move on a bit. I use the term stable heart failure patient, but there really is no such thing as a stable heart failure patient. They oscillate through their life, and that's why it's important to have close follow-up. That's why it's important to optimize them aggressively. So then I pose the question, is there a stable COPD patient? So I think this is the time I'm going to pass it over to Dr. Licskai, and I'm going to be mute for a moment.
Thank you, Bob. So I want to just follow Bob's lead and take the participants through a parallel journey with COPD, looking at what we can learn from the cardiology experience. So I'm going to pose the very same question that Bob posed. My patients need to take so many medications. What are the goals that we have for COPD management? Well, they're the same as for heart failure management. We want to improve symptoms. We want to reduce exacerbations and hospitalizations. We have new evidence published in the last 2 years that we can also reduce mortality, and we should be looking at getting patients on optimal therapy as quickly as possible. And so for patients with moderate to severe COPD, similar to patients with heart failure, we're on a pathway, in this case, to triple therapy. Of course, in the heart failure case, for heart failure reduced ejection fraction, a pathway to quadruple therapy. But our goals are the same. Canadian guidelines and our GOLD guidelines, which are the international guidelines that provide advice on how to manage patients, have really frame shifted in the last few years. And this slide is meant to show that frame shift. So based on the Canadian guidelines, we would have said until 2 years ago, for mild patients with COPD, just use Ventolin, just use a short-acting beta agonist as needed. Now the recommendation is frame shift. Actually start everyone with a diagnosis of COPD who is symptomatic on a long-acting bronchodilator, and most of the time that's a long-acting antimuscarinic agent like Spiriva or Incruse, for example. And then they split the group into low risk of exacerbation and high risk of exacerbation. For individuals that don't have frequent flare-ups, meaning less than 2 prednisone or antibiotic, the need for prednisone or antibiotics less than twice in a year, or who have not been hospitalized, but who are symptomatic, who are short of breath. a dual bronchodilator is now the first choice because it is superior for symptom relief, for relief of shortness of breath, than is a mono bronchodilator. So again, a frame shift, getting them onto optimal therapy sooner rather than using a fail first strategy. And for those at high risk, like Dr. McKelvie's Entresto story, for those that have been hospitalized, for those that are having 2 or more exacerbations per year that require prednisone or antibiotics, the frequent exacerbators, the first choice is triple therapy with an inhaled corticosteroid, a long-acting antimuscarinic agent, or a long-acting beta agonist, such as with a Breztri or Trelegy. And of course, any patient that has a component of asthma needs to have an inhaled corticosteroid. And if they have fixed airflow obstruction, meaning a component of COPD, first choice is in an ICS LABA combination inhaler, and then advancing to triple if required. And this is what the new guideline would look like then: low symptom burden, low exacerbation risk, a long-acting bronchodilator, low risk of exacerbation but symptomatic, dual and still experiencing symptoms, advanced to triple, high risk, 2 or more exacerbations per year or a hospitalization, initial triple therapy to benefit from mortality reduction and reduced exacerbations, and then advance beyond that if necessary. And again, heart failure has really led the way. Our cardiologists are teaching us something. This is the Kaplan-Meier curve of someone after a hospitalization. And we really are racing against the Kaplan-Meier curve in the first year after a hospitalization. 15 or 20% of those people will die. And so we want them on the best therapy that will improve symptoms and quality of life, that will reduce their risk of future exacerbation and will reduce their risk of dying, the same as with heart failure. And we can do this. We now have very effective therapies to both reduce exacerbations and mortality. But I maybe show you, as with Bob, I have a blank slide, not really blank. But if we wanted to just discuss the data, and I'll just use this to do it, there really are 2 very large trials: the IMPACT trial that looked at Trelegy and the ETHOS trial that looked at Breztri, both single inhaler triple therapies in populations that are moderate and high risk. So these were people that had at least 1 exacerbation in the prior year, and a proportion of them had 2 or more. And so these 18,000 people were evaluated in randomized control trials, 2 separate trials, and in both there was an identification that triple therapy was superior to dual bronchodilator therapy in this higher risk population. How is it superior? It reduced the exacerbation rate compared to active treatment with dual bronchodilators by about 25%. It reduced the hospitalization rate, and perhaps most impressively, for the first time in a COPD-related pharmacologic trial, there was around a 1% absolute reduction in mortality in a year, or around a 30 or 40% relative reduction in mortality. So if you looked at the number needed to treat, if you treated around 80 people, 88 people with triple therapy versus dual bronchodilator therapy, you would save 1 life. So again, as Bob would indicate, for these patients like our patient here who had 2 exacerbations, 2 episodes of bronchitis in the past 12 months that needed prednisone or antibiotics, these are individuals now that should be on triple therapy. That is the Canadian and the international recommendation for their current management. And of course, then a permission to proceed to get people on this in primary care practices. You'll notice that this patient is on open triple therapy, Symbicort. I'm sorry, he's not even on triple therapy. He's just on ICS/LABA, only on Symbicort. And so there really is an opportunity, one, to advance to triple, and two, consider single inhaler triple therapy. And as Bob did, I also then want to show you how we're doing in this high-risk population in best care, working alongside and supporting primary care providers in their own practice. And so at the individual's most recent follow-up, these Gold E patients, these high-risk individuals, up to 80% of them were now on an open triple or a closed triple. So closed triple is single inhaler therapy like Breztri or Trelegy, and open triple would be something like Breo and Spiriva or Symbicort and Spiriva. The challenge question, I guess, is with this population still on an open triple, are we or should we be advancing them to a closed triple or single inhaler therapy? I think the general feeling amongst experts in the field is that now that we have compelling mortality evidence and compelling exacerbation reduction evidence in favor of single inhaler triple therapy, that we should be having a conversation with our patients who are on an open triple about switching to closed triple for the mortality benefit and perhaps for additional exacerbation reduction. And one of the reasons this combination may be substantially more effective is that patients are delivering the medication more effectively because they only have one controller device to learn how to use properly and likely are delivering more effectively. There may be other advantages to delivering all three drugs in the same device at the same time. Similar to Bob's point with heart failure reduced ejection fraction is that we should get patients on triple therapy as quickly as possible. I just want to reiterate that in COPD, and certainly in moderate to severe COPD, we should be on this pathway to triple. We should get them there as quickly as possible because we're racing against the Kaplan-Meier curve and we want to reduce hospitalizations and ED visits. And I don't have the time to show you evidence, but there is real world evidence to support this position in COPD, and our guidelines are in favor and have created a frame shift so we can get people on faster. So let's move from COPD back to the conversation about how can we implement these recommendations in practice, and how does best care and primary care support and empower primary care practitioners to deliver on these in complex practices, in complex patients. And so I want to, for those of you who may not know about best care, just briefly introduce it and then pass back to Bob to talk about the health system innovation that has been led in London Middlesex related to this initiative. And so the Best Care and Primary Care program is a frontline clinical program. It's operated by a not-for-profit corporation. It is led by a community board of governors that you see here. It is funded by the Ministry of Health, and this year moved from an Ontario Health West regional program to an Ontario Health provincial program, where we report to the corporate office in Toronto, and currently at about 270 sites across Ontario. Bob?
Yeah, thanks, Chris. So the question is, why does the healthcare system need best care in primary care? So I've thought about this for many, many years, probably 25 at least. And I realize that the vast majority of patients are managed by primary care. This is not something I have to tell you. And there are significant capacity limitations in primary care. The health system is more reactive than proactive, preventative. In other words, we are very much a hospital-based type of system. When it comes to the community, we lack a lot of infrastructure that we need. Chronic disease management is complex, and I truly believe it requires a team. And structured, standardized chronic disease management strategy is required to improve patient outcomes and health system performance. We no longer need to be looking at, COPD versus heart failure. We need to be looking at both. So interestingly, when I came to Western back in 2016, I ran into this guy called Dr. Licskai. And when we talked about this program, it is something that I've been looking for the last, as I said in this quote, 30 years. Next slide. Now, Dr. Licskai and I have worked together now over the last 4 or 5, actually more years than that, I suppose now. And we did look at, we mapped what heart failure patients have to navigate. And this is one of the figures from the papers we published in the BMC Health Services Research. And you can see it's complex for the patient to navigate through the system. There's community and home health care, there's primary health care, there's urgent health care, there's secondary health care. They come to the hospital, they see specialty care. It's very much fragmented, but importantly, primary care is involved in more than 50% of the interactions. So primary care is front and center with regards to heart failure management. Next slide. Now, the structure in Middlesex London in terms of heart failure, as it says here, this is the current state. So when I talk about thinking about this for 25 years or more, I chaired the committee for core health that looks after cardiovascular disease and heart failure. And we came up with an idea about a spoke, you can see on the top, a community hub, and a tertiary node. So the spoke would be anyone practicing medicine independently. It's listed in the panel on the left. And truly, as I practice in my own cardiology clinic, I would be considered a spoke. At the opposite end of the spectrum would be the tertiary node, which would be the heart failure clinic. In between, we had what was called a community hub. And it was more difficult to define a community hub and to think about how to get resources in there. So Alex Smith, who's on here tonight, led the whole idea about, this change in how we manage heart failure. So if we go to the next slide, what we thought about was, and where I think Best Care fits in so nicely, is it can allow for a community hub to be present in primary care, because Best Care would support the optimization of heart failure patients. And you can see from this slide that we need to develop intercommunication so that Best Care would communicate not only with the heart failure team at University Hospital, but also with St. Joseph's Heart Failure Clinic, so that there'd be to and fro interaction. And it would also link with the supportive services down below, the CC2H and telehome care. So I think through this process, Best Care would function to support primary care, to allow the optimization I was talking about before in an effective fashion. Next slide. So I'll pass it back to Dr. Licskai with regards to Best Care and primary care.
I think many of you likely participate or are aware of Best Care and primary care, but this is an opportunity really for Bob and I just to set some context or to provide an update. And so when we talk about best care in primary care, we really want to have you frame around 2 or 3 lanes. First, we want you to think about it as an effective model of care for chronic disease management. We want you to think about it as a repeatable platform. So not as a heart failure program or a COPD program, but really as an approach to multiple chronic diseases that supports, that empowers, that adds capacity to the system. And I think what we have learned over the last 5 or 6 years is that best care can be an instrument for health system transformation. And the way that it can do that is by supporting and empowering primary care. Again, looking at that shift from downstream acute care, hospital-based care, to upstream in primary care, more proactive, more preventive, and more effective. So what is best care in primary care in more detail? It's a complete knowledge translation package. If it says that this intervention should happen in primary care, best care is there to create an interdisciplinary team in primary care practices and to support the delivery of these care elements. It is in person. It is whole of person care. It's pharmacologic and non-pharmacologic. It's to support social and psychological needs, and it's evidence-based. Every intervention is an intervention that's recommended by national or international guidelines and or Ontario health quality standards. An educator who is also a case manager and a guideline expert is embedded in the practice where patients normally receive care, working alongside, in collaboration with, and under the supervision of the patient's primary care provider. It's proactive and upstream and preventive, and it for sure reduces hospitalizations and ED visits and unscheduled primary care visits based on the world literature and the highest level of scientific evidence that specifically evaluates the best care program. It really does support system integration, building up from primary care, and I'll show you a couple of examples of that. So first, it is a complete knowledge translation program. It delivers all elements of evidence-based care, and we know it does because we measure it in every single visit. And last year, we measured it in 26,000 such visits. What you're seeing on the right is just a sample of a standard a report that outlines the Ontario health quality standards and shows how we're delivering them in COPD and heart failure. If it's in the guidelines, we're doing it. We know we're doing it because we're measuring it. We're reporting it quarterly. It has a robust quality assurance program. It's standardized program. It's the same at every site across 270 sites in Ontario. It's currently a program last year that was trusted by 13,000 primary care providers in 12 Ontario health teams, 16,000 patients in 26,000 visits. You can see the Ontario health teams that we support on the left panel. On the right panel, you can see where best care exists in southwestern Ontario, where we have the largest presence. In Eastern Ontario, where we have partnered sites that we collaborate through a memorandum of understanding. And these are potential sites across to Northern Ontario. We have submitted a bold plan to Ontario Health and the Ministry of Health for a provincial spread and scale of the best care program to support and achieve the objectives that we have set out. We are currently working with 12 accelerated Ontario health teams to find ways to support and expand the program into those regions. I'm going to say it's a world-leading primary care program, and we're feeling more and more confident now that we have had a publication accepted in the BMJ journal Thorax. It is accepted and in press currently. This is a world-leading top 10% pulmonary medicine journal. So that I will walk through in just a minute. But in terms of what we're doing to support the health system, we are truly delivering on the elements of the IHI quadruple aim. We have 2 peer-reviewed publications that describe provider experience, describe improved provider experience, and we have 1,300 primary care providers that support us every year and with their participation identify that their experience is positive. From a patient experience point of view, we have 2 direct peer-reviewed publications and an additional 4 quality of life studies published again to demonstrate the impact. In terms of improved health outcomes, we have 5 peer-reviewed publications, really the highest levels of scientific evidence, including randomized controlled trials. And we have 2 robust formal cost effectiveness analyses, one in Canada and one examining 3 other countries, 2 separate publications. I would boldly say to you, there is no chronic disease management program in primary care that has this level of evidence in the world that we are aware of. Let's take a moment to look at the thorax paper. What you will see very soon when it is published are the impact of best care COPD on the provincial health system in Ontario. Let me orient you for just a moment. On the right panel, these are COPD-related emergency department visits. On the left panel, hospitalization. Let's focus on the ED visits, if you will, for a moment. This is a graphic that represents 2,400, almost 2,500 best care COPD patients treated in primary care. Time 0 is when they entered the best care program. Each of these patients was linked to the provincial OHT dataset through ICES. So what you see to the left panel is 36 months, 3 years of emergency department visit data on these patients prior to ever coming to best care, before we ever met them. What you can see is that there was a definite inclining trend in ED visits in this population over a 3-year interval. As is done in an interrupted time series analysis, a counterfactual control is created based on the pre-intervention trend shown here in the stippled line. What you actually see is a dramatic reduction, statistically significant reduction in ED visits immediately, and a declining slope over the next 3 years, indicating that best care in primary care completely changes the trajectory for emergency department visits and hospitalizations or COPD-related events, but also not shown here for all-cause ED visits and hospitalizations, and most interesting perhaps also for cardiovascular-related hospitalization. This is a first ever study, interrupted time series study done on a population basis to show the impact of primary care IDM on a health system. Best care in primary care, it's an approach to disease management. It is supporting primary care, resourcing primary care to help them to do the work that they want to do on behalf of their patient. So we started out with an asthma program, we added a COPD program and a heart failure program and an atrial fibrillation program. And this year we'll be launching a lung cancer screening project, a major initiative over the next 2 years as a demonstration project, which will be for the early diagnosis of COPD and to support primary care practices to find lung cancer screen eligible patients in their practice. And Dr. Vladimir Hashchinsky, that many of you know, is very interested in a dementia prevention initiative, holistic brain health. There may be applications to mental health and anxiety, depression and anxiety support. there may be an opportunity for hypertension management, etc. But if you will, a platform, an approach to chronic disease management. I want to spend just a minute talking about an example from Northern Ontario that really could apply, I think, to any Ontario health team, but certainly applies across the North. So just over 18 months ago, we submitted a joint application with North Bay Regional Health Centre and the Nipissing Wellness Ontario Health Team to create a heart failure project. Before Dr. Yari Twomey, who trained under Bob, before he headed back to North Bay, we met with Yari, Bob, and I, and Madonna Ferroni to have a conversation about how Best Care could support vertical integration, could support his specialty practice in North Bay and area. And so in the course of 18 months, we hired a heart failure educator case manager. We embedded him in a network of primary care practices that we worked to create. Virtually every practice in North Bay, Mattawa, Sturgeon Falls, Powassan, the Indigenous Hub, are now part of the community heart failure network, the hub that Bob is talking about. We have an unattached heart failure clinic at North Bay Regional Health Centre. We have vertical integration. We're sharing patients with Dr. Twomey right along the lines of the vision that Bob was presenting. This year, we have then now moved to COPD. So they are supporting a COPD educator case manager. So now we'll have COPD and heart failure across a broad community network. The educator case managers connecting to a community network with 50 individuals doing the same type of work. And we will be launching in support of the Ontario Lung Cancer Screening Program out of Sudbury, a project in Sudbury and North Bay to build and grow the regional integration, the regional transformation. So one example of how Best Care, or more importantly perhaps, of how primary care with some support from Best Care can really lead the charge to transform the health system. What about Best Care? In summary, it's active early case identification, and we're going to demonstrate that in our early diagnosis COPD and lung cancer screening project this year. It's for diagnosis and comprehensive treatment of asthma, severe asthma, COPD, heart failure, lung cancer, and as we move ahead, hopefully other chronic conditions. It's leading through primary care, so it is a support or an empowerment for primary care practitioners to transform our health system. It's implementing care standards around the cancer journey. It's optimizing pre- and post-cancer care. It's creating effective communities of care, a network of educator case managers more than 50 strong, a network of primary care providers now 1,300 strong, providing services for asthma, COPD, and heart failure aligned with Ontario Health and international standards. And we have the strongest body of evidence, I would suggest, nationally and internationally, that we are indeed improving system capacity by reducing hospitalizations and ED visits, by reducing unscheduled urgent visits to primary care. We are supporting vertical integration, unburdening specialty care by providing advanced care in primary care. And we are a cost-effective solution, and it is, as I said, a repeatable platform. So I want to thank the London Middlesex Primary Care Alliance and Dr. McKelvie and our broader educator case manager team that you see here, our broad team that supports all of this work. And of course, all of you that participate currently in Best Care for your support, for your trust, and for the incredible outcomes that you have achieved. So I think it's for me to stop share and then turn things back for questions, which I think will largely be for you, Bob. So I don't know, Bob, if you're moderating, or Melissa, or who is, but I'm going to stop talking.
Okay, I think Alex and or Melissa are going to do the screen the question sort of thing. Is that?
Yep, so there's 2 questions in the chat right now. I'll just read the first one. From YM Lamb, it's when is the optimal time to start the 4-pillar of treatment for heart failure before any hospitalization? Is before any event or trigger to put patients really in heart failure state require hospitalization?
Yeah, so the optimal time is when you first make the diagnosis of heart failure. So if the diagnosis of heart failure was made in the community, in other words, you have identified that the patient has heart failure and it's reduced EF heart failure, then even prior to involving a specialist, the medications I mentioned could be started. And the order of starting them, as I mentioned, if they're, you would start with an SGLT2 inhibitor before you know the ejection fraction. Once you know the ejection fraction, you start adding in the other medications. So the most effective way to add them in would be the SGLT2 inhibitor first, as I mentioned, because it's 1 dose. Probably start the MRA next because it's 2 doses. Potentially start the beta blocker after that, or Entresto. But that's how it would go. If the patient's admitted to hospital with de novo heart failure, then ideally the hospital team gets them on the lowest doses of each medication prior to discharge. But if they don't get them on the lowest doses of all medications before discharge, that isn't a signal that they shouldn't have all 4 medications. It just means they couldn't get it done in hospital, and it should be continued on by the primary care physician in the early post-discharge period.
Bob, I think I've heard you say that you sometimes start more than 1 medication at a time. So do you do that?
Yeah, you can do that. So depending on the situation, you could start an SGLT2 inhibitor and a beta blocker at the same time. For example, the SGLT2 inhibitor would cause a bit of diuresis, and the important thing is the mechanism of action of those 2 drugs don't overlap. So it would be quite reasonable to do that. Similarly, you could start an MRA and a beta blocker at the same time because the mechanisms of action don't overlap. And ideally, then you would get them back into your office within a couple of weeks to start adding on the other medications. As I said, we would like to get them optimized in 3 months, and at the outer range, 6 months. So again, as we've talked about best care tonight, the best care educator would be very useful in terms of helping with this optimization and following the things that need to be followed to efficiently and quickly optimize these people. Yeah.
Thank you. So I'll read the second one here from Nisha. Just a reminder, if anyone on the call has a question, they're welcome to raise their hand and speak to it out loud. But this one from Nisha is, I'm interested in your commentary on beta blocker use in patients with comorbid asthma and CHF. Optimize the other meds first.
Okay, so the question is a patient who has COPD and heart failure. Is that? I think that's the gist of the question.
Or asthma, Bob, I think.
Oh, asthma. Okay. So what I'll do is I'm just going to comment on about the heart rate thing. And then Chris, if you want to jump in about the asthma thing / COPD. So in terms of heart rate, I would continue until So if you start at 2.5 of bisoprolol in a patient with a heart rate of 75 to 80, as long as the heart rate is still above 60 beats per minute, then I would continue um, to optimize to the full dose of 10 milligrams daily. Chris, do you want to jump in about the asthma COPD story?
Yeah, so I'm generally not concerned about the use of beta blockade in the COPD population. I think there's clear reason to do it from a heart failure point of view, and the probability of creating a problem with bronchoconstriction in the COPD population is small. Now, I know that's not the question that was asked, and so let me get to the question that was asked. And that was, well, what about asthma? And so, again, we know beta blockers are very effective, and as Bob has presented, and as you are aware, at improving outcomes for heart failure, reduced ejection fraction. So there is a high priority to have the patient on that medication. Bisoprolol, of course, is a cardioselective beta blocker, and so mostly blocking beta 1, and the dosing is low. So really, except for the most brittle and uncontrolled asthma patients, I would recommend that the patient be treated along the heart failure algorithm, including the addition of bisoprolol, as the guidelines would outline. I would start low and work up. Most patients with asthma that is reasonably well controlled can tolerate a low dose of beta blocker without difficulty. And if they are experiencing bronchoconstriction, they can use additional Ventolin to overcome the beta 1 blockade that might be slightly crossing over to beta 2. So I think it can be very safely done in asthma as well, with the caveat, if you had somebody with uncontrolled or severe asthma, we would want to get that under control before introducing the beta blockade. I don't know, Bob, if you would add anything different to that, but that would generally be my recommendation.
Yeah, no, that's where I would go. And then as you were speaking, I was just thinking if there's concern about the use of beta blocker, then there's another medication called ivabradine that is a medication that slows the heart rate. It doesn't affect the bronchi. In other words, there's no bronchospastic part to it. It doesn't affect the blood pressure, so no worries there. And this is where the whole idea of co-management comes into play, because we're using a beta blocker, obviously, to reduce the heart rate. There's other reasons for using it. But a patient with an elevated heart rate is at risk because of having an elevated heart rate. So ivabradine is a drug that will reduce the heart rate without affecting lung function. But I would say if you're at that stage, that's when, one, the fact that you've got the ability to have support with COPD and heart failure from the best care educator, and then the opportunity to interact with the heart failure clinic or the cardiologist with regards to the use of a drug, ivabradine, which we didn't discuss tonight. I realize that, but that is where you would go.
Thank you. The next question here is, what heart rate do you consider too low when titrating beta blocker in an asymptomatic patient?
Oh, too low would be less than 60, I think. I think I'm using that as a safety thing. When I'm imagining if even if they're into the 50s and it's sinus rhythm with no evidence of first degree heart block, then I'm still comfortable. But I think in order to allow people to be comfortable, as long as it's above 60 beats per minute, it would be fine.
I don't see any other questions here, but I'll go to some of the ones that were submitted with the registration.
Sure.
So someone's asking about an update on reduced benefits of beta blockers in general or in the elderly. Balancing multi-medication approach, its real-life side effect impact on all ages.
Yeah, so I saw that question before we came in tonight, and I'll answer the question. If the person is actually in the room tonight, they could elaborate on the rationale for the question. So essentially, for heart failure reduced EF, a patient would be on a beta blocker unless there's a contraindication, such as we talked about, that Dr. Licskai mentioned with asthma. Regardless of age, this is not the elderly benefit to the same extent with heart failure reduced EF. If we're talking about heart failure preserved EF, because I noticed that the question was heart failure unspecified ejection fraction, then those with heart failure preserved EF, there's no rationale necessarily to use a beta blocker to treat the heart failure. The only reason that a beta blocker would be used in that particular situation would be if they have coronary disease and you're trying to treat angina. You might think the beta blocker is beneficial to treat blood pressure, but otherwise, I wouldn't necessarily use a beta blocker in heart failure preserved EF, but definitely in reduced EF. I would use it regardless of age. And if the person's there and they would like to follow up with a question, and the other set, and because I'm not sure exactly what they had read to result in asking that question, it would be helpful if I knew so I could further elaborate if necessary.
Doesn't look like the person who asked the question is on tonight.
Okay.
A couple other questions came in beforehand as well. One's asking when to consult EP for CHF patients.
So the answer to that question is, if you have found your heart failure reduced EF patient and the medications have not been optimized, then there's no reason to consult EP until you've completely optimized the low EF patient and reassess the ejection fraction. That recommendation is for a primary prevention ICD or CRT therapy. If it's a matter of secondary prevention, in other words, the patient has collapsed because of VT or VF, then that's a totally different story. But if we're talking about contacting an EP's physician for primary prevention with the use of an ICD or CRT, there's no reason to consult them until you've done your work optimizing the medical therapy.
And then, Bob, what's the ejection fraction cut that you would use for that, or would you?
Oh, no, good question, Chris. Thank you. An ejection fraction over 35%, you wouldn't refer for an ICD or CRT therapy. You wouldn't refer to the EP specialist. Below that, after you've optimized the patient completely, and if their EF doesn't come up above 35%, then you would make the referral.
Okay. Another question ahead of time we got was practical workflow tips for solo family doctors and CHF management.
Oh, I'm sorry, Melissa, repeat that.
It's just a comment about asking for practical workflow tips for solo family doctors and CHF management.
What practical tips in terms of
Workflow, I think,
Workflow
Bob, in
tips?
terms of how does that mean how to get things done?
Oh, okay. Well, I mean, obviously, again, the scenario can be variable, but if a solo family physician is faced with a patient who's short of breath and has other signs and symptoms that would make them think that the patient has heart failure, then it would be useful to get a chest x-ray, an ECG, and order an echocardiogram. Obviously, to do a good clinical assessment, physical assessment, look at the jugular venous pressure, listen to their chest, look for evidence of peripheral edema. And then once they've made the diagnosis that the patient truly does have clinical heart failure, then, as I said, the first drug to start would be an SGLT2 inhibitor. And once they get the echocardiogram results back with regards to the ejection fraction, then add the other medications in as we've discussed based on the ejection fraction. They can, the other thing I want to add is, and I want to support that even while waiting for the specialist to weigh in, there's a lot that can be done by the family doctor and should be done by the family doctor appropriately, because this is what's led to delays over the years with regards to optimizing these patients.
Perfect. Thank you. Yeah, that's all the questions I had. Just
Okay.
2 minutes left here. I just wanted another check in the room. If any questions, comments, feel free to come off mute. Just another chat to thank you, and so we'll wrap up here. Yeah, I wanted to send a big thank you to both of you for coming today and presenting, as well as the people in the background, Alex and Madonna, to help support this and make this happen. We will be posting this recording of this town hall to our website, and please reach out at any time if you have any questions or you want to know how to connect in with our presenters or best care. And thank you so much for coming tonight, and have a great rest of your night.
Great. Thank you very much.
Have a great night, everybody.
Good night.
Thank you for your interest.
Yep. Thank you.